Thank you, Karen. Thank you, everyone. Good morning. Welcome. Thank you for joining us. I have the great pleasure of being the CEO of the Canadian Nurses Association, and every chance I have to say it, I'm very happy to say it's the best job I've had in my whole career. And since I'm older, and people say 60's not old. Ask a 30-year-old if 60's old. And yeah, 60's old. It all depends on where you are on the scale. And since it's probably my last job of this kind, it's really great that the last one's a really, really, really great job. And it's a great honor to hold a position that only 11 other people have held since we opened 110 years ago. And despite all our problems and all our challenges in nursing, I've loved my whole career. So I'm unabashedly happy to talk about it. Of course, there's days when I just want to put a fork in my head, and just end it. But the career never looked back. And I had wanted to be a surgeon my whole life. My grandmother was a director of nursing and used to drag us around the hospital to meet people in the old days when you could just walk into ORs and stuff. That was the early 60s. And I was fascinated by what was happening behind operating room doors, and I thought, I'm going to be a surgeon. And then my, at the time, high school girlfriend's mom got me a job as an orderly in a hospital, and I went into an emergency department for the first time. That was where I was assigned. I thought it was very important because I was working in the emergency room, brand new, off the street, 18-year-old. What the hell was I going to do? But I felt very important going in there. And within probably 1 hour, I went, oh my God, my whole career was the wrong thing. I was watching what those women were doing, and I thought, that totally fascinated me. And I never, ever thought about medicine again from that minute on. So I come to the table not to be Pollyanna about the problems, because there's problems and we got to get them fixed, of course, or ameliorated at least, but really as someone who really does enjoy the career and happy to talk about it. Whoops, going the wrong direction. So now you're going to see my challenge, because I can't see those, and it's not attached to this. So I have to do a very simple thing, which is hit 2 buttons. Watch how hard that will be over the next hour. Pour mes collègues francophones, je vais protéger vos oreilles, et je vais parler pour la plupart en anglais, because my French was learned at the feet of Diane Dufresne, and in one of her 1960s, 1970s, very high period when it was a combination of English and French and Greek and swearing. And so my French is Diane Dufresne French, and it's not repeatable when we're being recorded. So I will, for the most part, speak English, and most of my slides are translated. Happy to bring greetings from our amazing board of directors. I've been around CNA in a number of roles through the years and never seen a board like we have now. Smart, strong, courageous, and of course one of our great leaders is your great leader, Karen, who's here today. And you can see Karen, you could see her if I had followed my own instructions. And honest to God, someone's going to have to discipline me and say that the right slide isn't on the screen, okay? It's not working, John. I think I did hit it. I was changing on one side. All right, so there's hope. Look at this side.
Stop advancing.
No, I need to go back. Okay, let's go back to the board picture. Pretend you didn't see all that. Start again. Are we going to try it now, John? Technology, honest to God. Okay, look here. This is the board of directors, and on the far right, the gentleman to the farthest right is Tim Guest, who is our incoming president, and he's from Nova Scotia. So we have, for the first time in a long time, an East Coast president. We seem to have been Ontario and Western focused for a long time, and so you'll have lots of time to meet and see Tim through the coming years, I'm sure. Are we? There we go. Still not going on that side. This is some of my staff, and in the Hall of Honor at in the center block, at Parliament Hill, where we spend a lot of time doing work. And I think this is one of our lobby days. And on the far right in that picture, you'll see Dr. Claire Becker, who's the current president of CNA, and who, as of last night, asked me to bring her greetings and sorry that she couldn't be with you. We tried to get Tim or Claire to join us, but as we tend to do, we split up tasks and are in different parts of the country doing different things on the same day. Okay, this is the one I'm going to pay attention to. So there's a few recurring themes I want to share before I get into a little bit of the meat of what Lori and her team asked me to do, and some of them are here. First of all, we know Canadians have very, very high expectations of the healthcare system across the country, or healthcare systems, because there's about 14 or more of them, but 13 jurisdictions plus the feds, prisons, veterans cares, and so on. So there's a lot of different health systems, and Canadians expect them to be fantastic. And they tell us, some of this polling was done just before Mr. Trudeau was elected in the fall of 2015, but no indication much has changed, that they know that their expectations sometimes aren't even really very realistic. They just expect it to be great, more than they expect education to be great or roads to be great. They want healthcare to be fantastic, responsive, get me in on time, don't hurt me, all the kinds of things any of us would want. Here in New Brunswick, as you will know from surveys just released over the last week, healthcare is number one in the list of concerns, and it's usually in the top three across the country. Sometimes people say the economy, jobs, and so on, but it's pretty much always in the top three. So very high expectations, and a very high expectation when you poll the public that nurses will do something to help transform the system to make it better. And by that, I mean actually do things, right? Not angst about it and talk about it, but actually get out there, move policy, help them create the legislation. And if you look at where we stand in who they expect to do that, they expect that more from health providers than politicians. So I think they know politicians are well-intended, and I actually believe they are. But they aren't usually people who work in healthcare. They might have been a car salesman before, or a fisherman. You don't know what they were. When they get appointed to lead a ministry, they need great advice. And that's part of the job of professional associations, of course. Let me, and of course, as I said on the bottom, is it moving now? They expect us also to provide a lot of great care. So I'm always conscious that the expectations of that we place on the backs of nurses are very high. Do a lot of care, well, everybody's working hard in every job pretty much, but so you're working hard, provide great care, be attentive, be patient-focused, communicate well with us, and when that's all done, also advocate, join committees, join your professional association. It's a lot to ask of people, and we know that. I always say, as a good Anglican, let us pray, but let us pray is not working on this side this morning. So
2-second delay.
There's a 2-second delay. Okay, it sounds like the story of my life. All right. Another message I guess I wanted to share is this one, which is just simply a quote from James Thurber. One of the jobs I have at CNA, or I think one of the responsibilities I have, is to do these things, just to be aware. We can't afford to spend a ton of time looking back, because lots of things were done that we don't love or would have changed differently over the last 100 years. You have to be aware of it. Somebody said yesterday about looking forward, and I always was thinking about Sister Elizabeth Davis' comment about growing a dory, where you keep your eye on the shore that you're leaving, but you still go forward in the other direction. Keep a sort of safe distance so you can see it and learn from it, but go forward you must. So my job, especially in a very rapidly changing environment, CNA is changing a lot, is not to scare the bejesus out of the staff every day and have people worried. I mean, if I was crumbling and scared and worried, that would not be a very helpful way to run an organization. It would not be helpful to you. You're all our members, or most of you are our members. But rather to look around, think about what's coming down the pike, where could we intervene to make things better, take advantage of timing, and so on. And the other message is this one. And it may seem obvious, you've all heard a million times, you can't get new results doing the same old thing, but it's actually sort of true. And we have a bit of a history sometimes of sort of reverting to form, which is to generally repeat what we've done before. And in no place do we do it better than hospital care. Right? We've known since the 70s from pretty hard evidence, for example, that the best thing would be to keep most people out of hospitals and to have a very different sort of health system. We have one of the most hospital-intensive acute care rescue treatment-focused systems in the world because you can do something. And I always say fluoride in toothpaste is very boring. Is it in toothpaste or water? It's in both, maybe. It's really boring, but it works. It just takes a couple of generations. And who cares if your teeth fall out in 14 years? I'm not elected at that point. But I can buy a helicopter in the next 2 years, right, and make a trauma unit happen. So we revert, and governments revert back to, we don't know what else to do, for God's sakes, just build a hospital, right? Build some walls and build something, and something good will happen. But we know now that there's probably some other ways we could behave that make things happen in a different way. And we're going to talk about some of those today. He's going to try again. So, Lori and her team had asked me to talk about general trends around the world and what we have to pay attention to and what we are paying attention to at CNA and we need to across nursing. What kind of health systems do we need and what kind of nursing do we need? And we're going to ask you about that through the day too. What should nursing look like in New Brunswick in 2025? Never mind 100 years from now. Even 5 years from now, what should be different to meet population health needs? And how do we get to some of those? What kind of structures need to be in place? So that's what I'm going to talk about. Oh God, we're back on track. Good. Okay. So some of the trends around the world will already be very well known to you, and I'm not going to beat them to death. We are all aging rapidly, and in no place more rapidly than New Brunswick, I am told, when we look across the country, right? The oldest population, but it's everywhere. I live in a small farm town where, as I always say, there's this giant sucking sound of young people leaving, and they come back for Christmas, they don't come back to work and build houses. Because we're close enough to Ottawa where I live, there's a little bit of the overflow of relatively wealthier nurses and doctors and so on building, houses in the country and so on. But mostly, it's a lot of really, really old people. And Canada is one of the 13 countries that will be called a super aging country by 2020. Is that a familiar term to people? That's where 20% of the population or more is over 65. And so that's a lot of people. And in case you're not tuned in, 2020 is about 18 months from now, right? It's not like 100 years from now. So it's not a theory anymore. How are we going to take care of them? Like, how are we actually going to take care of them? It's an interesting question. The study out of McGill came out about 2-3 weeks ago, posited that the biggest challenge in caring for the aging, anybody have a guess? Caring for that super aging group? You're all nurses. No guess? Who's going to look after them is one, but you know what they concluded? How are we going to drive them all around? That was actually the biggest actual logistical problem. How do you move them around when millions of them can't drive anymore and have to get to appointments, have to get groceries? So short of Amazon stepping in and delivering, which might be part, and drones delivering your drugs, right? We've talked about that. True, because they can do it in an hour instead of 2 days or whatever. That's actually a real problem. And where I live in rural, middle of farmland in Ontario, I think about it for myself. Like, I'm not going to be able to live here when I'm older. Because how am I going to get anything or get anywhere when I'm probably not very far from it now, I'll lose the license, right? Because you're too dangerous to be driving. Can't drive at night anymore, and I'm only 60. God, I'm confessing. Anyway, aging is an issue, and the companion of aging, of course, is chronic disease. And we have plenty of it. And the more of those you have, the more medications you use. The more medications you use, the more times you visit doctors and emerge. The more times you go to emerge, the more admissions you have. And we know that by the time you're 70 or 75, you're carrying 3 or more of those chronic diseases, and we know about polypharmacy and so on. And so hence the constant drive to back it up down the pike so that we prevent those chronic diseases, so that people take less meds and less of that plays out. Every minute you spend in an inpatient facility is the highest cost driver in the system, right? It's length of stay. So if we can keep people out of there, great. And if we can keep them out of emergency rooms, even better. Because we know when we take an old person from a nursing home to an emergency room, even for one visit, they're not quite the same when they go back. And they never recover the way young people bounce. I have a friend whose kid fell out of a 3rd floor window the other day in Vancouver. Bounced like a rubber ball and kind of, whoa, right? Sore as hell and full of bruises, but fine. I would fall off here and I'd be dead, right? Or I'd have a broken hip. But that's the reality. I mean, it's just how it is. Kids bounce, old people get worse every time. So let's not move them around and transfer them. We also have a problem with communicable diseases that we thought we had put to bed. Some of it is because we have people who think that vaccinations don't work, which just makes me want to, anyway, I'm not going to get into that because I'll just talk about it all day. But if you look at the heat maps of communicable diseases, anywhere where there's vaccines, they stop, the heat map stops. Heat maps intensity of the number of cases in a state or province. You can look at the dark blue until 1955 when you had to have it to go to public school. Boom, nothing. No measles, no chickenpox, whatever the vaccines are, measles, mumps, rubella, and so on. And yet we have people now saying, something's wrong with the vaccine, it doesn't work. And now we've got, 50,000 cases in Europe this year, and how many died? Anyway, and we had, of course, the scare of SARS. We had H1N1 in 2009. I think I asked you that yesterday. Was it 2009? And then Ebola. And I'm on the Chief Public Health Officer's Advisory Committee because of my role, not because I'm so great. The CEO of CNA is always there. And, that's a serious concern. What are we collectively going to do if people start to sneeze again, right? What are we going to do if there's a real outbreak of H1N1? And we're 100 years from Spanish flu, right? When millions and millions, a fifth of people in some countries died. And we really don't have any better way to control it now than we did then. So communicable disease is not as beaten down as we think. Some of them, like HIV, thank God, we have turned into a chronic condition when people would have died, but it's communicable disease is still an issue. And as climate changes and warmth moves further north, different kinds of diseases travel with it. Chronic disease and aging, or the care of chronic disease and aging, threatens to really overwhelm our systems, which really are structured to respond to acute care, treatment, rescue, and cure. And I won't fill the whole talk with personal examples, but I saw it so many times with my poor dear dead father who died in 2015 after 2 years of a dementia struggle post-stroke. And every time Dad even farted the wrong way, they took him to Emerge. So there's first of all that, right? So why are registered nurses who are capable transferring an old person to Emerge for minor things? Dad would fall from his wheelchair occasionally because he was always really active. So the wheelchair is no higher than I am. How much damage are you going to do? Right, falling to the floor, and he would get a little cut on his head. DNR bracelet on him already, advanced cancer not being treated, dementia for 2 years, ready, and wouldn't have wanted to live like that. You would have thought he was on the Olympic team every time he had a little thing go wrong with him. Off he goes to Emerge with a bunch of paramedics and lights and stars. Oh my God. So Christmas Eve, I get to Emerge, there's Dad on the stretcher. Hello, son. He's looking at the lights. Hello, dear, talking to the girls, right? Because he loved women walking around him all the time. And he's got a little cut here, and Buddy's on the phone, the doc. We're recording this, right? Just realized. A doctor is on the phone, phoning another physician in a major tertiary hospital, which will remain nameless, about a neurosurgical consult. So he's lovely, the young guy, the doctor, and I took him aside and I said, stop, just put a stitch in that. Give him back to me. We will take him back to the nursing home. There's nothing wrong with him. What are you going to do if he has a bleed? We're not going to consent to neurosurgery. That's what DNR means, and no treatment, no advanced treatment, right? It wasn't his fault. It's because the emergency room responds the same way to everybody. And that's why there's a 7-hour wait, because everybody gets care as though it's an emergency that has to be cured and treated. When in fact you could have a nice nurse-led clinic that's on this side of the door that just streams those people right into it. And every time I'm in Emerge, I sit there and pick them off and go, okay, she's got a UTI, he's got a broken finger, that one's got a sore ear. We could treat them all, right? We know exactly what needs to happen with them. So let the docs take care of the sick ones. The high intensity, unpredictable traumas and cardiacs and all that kind of stuff. And I have sat there and watched people who I thought, he's having a heart attack. Or I sat there once, I've had some care issues, thought that guy's got a kidney stone, I can just tell. You can see the sweat and the paleness and everything. Well, they're sitting there with all the rest of my dad and all the rest of them, right, waiting. So we haven't managed to adjust ourselves very well to the reality of the population that we're serving and what it needs, which is sometimes TLC. Or if you're in long-term care, God love you if you're working in long-term care, because we have such a hard time recruiting. Most of what I saw when I was there over Dad's 2 years being transferred was dehydration, constipation, UTI, chest infection. Like, I could have picked them off and said, okay, antibiotic, more fluids. Like, it's not that complicated. And nurses are able to do that if we unhinge their regulation and let them do it, or force them to do it. Access to long-term care and home care is problematic across the country. Most people would benefit from palliative and end-of-life care, and most don't get it. More than 3/4 of people who say they would want it and use it don't receive any palliative care, and most of them die in a hospital and say they don't want to die in a hospital. So again, think about costs, and most people have an ICU stay within the last year of their life, often within the last 2 weeks of their life. That's problematic. Now, as I said yesterday, if I'm out, you don't know me here, I'm out at the Costco and drop to the ground and have a heart attack and have to be in an ICU and then die, well, that's appropriate, probably, right? Because you don't know me, so I had an ICU stay in the last 2 weeks of my life because it mattered. I mean, not that they don't matter, but because it was appropriate. But if people have long-standing DNR issues and have proper palliative care, they usually can be managed in a different place unless they get very scared at the end, which happens, right? People suddenly are terrified or can't breathe or have pain. It's often the reason they suddenly say, just take me to emerge, and then they end up dying there. But we could probably do some of that care better. Here's another problem that all of us are facing. I need the sound for this, John, please. How can I give a machine mixed messages is a good question. If you haven't seen the show, it's called Getting On. There's an American version, but this is the original British one. And the nurse on the far side who said, "Can I go for my break now?" Jo Brand, is a nurse and wrote this series. And if you haven't seen it, it's the absolutely most realistic thing you will ever see about care in a ward. And it's a sort of elderly care ward in a general hospital in the NHS. It's absolutely brilliant. So this is obviously meant to be a little bit funny, but it speaks to the larger issue that we're concerned about, which is around patient safety and quality. Let's see if we can get these lined up again. I think they're not they're not in sync. John, can they? Are they? Okay, you guys keep me in line. So we have serious concerns about quality and safety across the system. And we've really been at it for probably 20 years, but certainly intensively for 15 or more. And the problems continue. We haven't really cracked it despite all our best efforts. And we have patient safety institutes and quality institutes and so on. A huge focus on it in hospitals across the country. But a lot of the outcomes are still a really serious concern. So here's one of them. I'm going to just use this one now. Okay. On any given day, more than 1,600 beds across the country are filled with people who don't need to be there, but they're there because we hurt them during the course of their care. So that's not because their cancer went bad or their trauma, they got an infection in their bone or something. It's really related to the care that we gave them, something we left in them, something we didn't give them, and so on. 1,600 beds a day in a system that's crying for people to have access to care. So add the 5,600 or so that are alternate level of care beds, people who are in them who don't need to be in them, who are usually elderly, often frail seniors, palliative care, nowhere else to go, but often long-term care patients. More than 7,000 beds a day across the country being used by people that don't need to be in them, because we have a hospital system and we don't have all the other pieces that need to be built around it. A lot of that long-term care, we haven't kept up, of course, with the trends, which is a hugely aging society that we just talked about, and built the kinds of facilities that they need. I hear a lot of lip service given to more home care for these patients, but I can tell you, again, just back to the personal example, if I was to have given home care to my dad, I would have had to retire and simply stay with him 24 hours a day for 2 years. What are you going to do with a person who just wanders in circles? He didn't do any damage or anything, but he might have hurt himself and needed to be toileted and all that kind of stuff. I mean, that's the reality. And home care is great for the hour a day that you have it, or the two visits, but otherwise you're on your own. So, absent some other way to take care of people, they end up sitting in hospital beds. And then we have a year-long wait for mental health care, a year-long wait for eye care, and so on. That's the reality. The bigger sadness, I suppose, is the number of people that don't survive. And as Chris says, we have 1 every 17 minutes dying in the system who's had some kind of adverse event that contributed to the end of their life. And I always have to ask Laurie and Karen to forgive me because they've heard me talk about this a million times, but if Air Canada lost a person every 17 minutes today, it would be shut down by noon. There's something wrong. Something's wrong, right? Stop the planes. Every time a 747 goes down, which is rare, they ground the fleet until they figure out what the hell happened. They're merciless about finding out the problem, but people need care, so on we go. You can't just say we'll close the hospital system, right? So I'm not saying that should happen, but the quality outcomes in many cases have not improved, and we're hurting a lot of people, which nobody goes to work to, and says, who can I mess with today? That's a problem. Where am I at? Oh. We talked a little bit earlier about having broader kinds of systems of care for people and attention to other pieces of what makes you healthy, and these are most of them: social, environmental, income, and so on. But as you saw, you will have seen in your papers here, health care is number one, and governments tend to fuel it. It's the highest expense for every government, even though we know that what would probably make most people healthier is higher income, is them not being treated in a racist way where they work, in their education being higher, right? In childcare being better. All the pieces that contribute to health would probably make a bigger bang for the buck, and there's ample evidence of that around the world, but we don't do a good job. We fuel the healthcare system and we don't know what else to do. In Ontario, we've had a program they're testing, you might have had one here too, around basic minimum income. And the new government came in and just shut it down. So we just don't believe that. Well, you can choose to not do it, but the evidence is what the evidence is. We're not going to do safe injection sites in Ontario anymore. No, not proving anywhere else. Don't believe that. Well, it saves lives. So if that's what you want to do, fine. If you just don't want to save any lives, then that's fine too. I mean, it's not fine, but that's your choice as voters to vote for that. But the evidence is the evidence. And that's why I always say in nursing, bring the evidence to the table. Put the ideology will drive the decision, but at least put the facts on the table. So in the end, the determinant of health that matters the most is this one. It's the choices people make, and that's just how it is around the world. So what do we do with all that information? So picture a lot of old people, need a lot of palliative and end-of-life care, need healthy aging care, need chronic disease management, a system that sits over here that's quite different. How do we handle that? The conundrum is this, and I've kind of said it before, that millions of us are working out full tilt. Most nurses I run into across the country aren't sitting anywhere eating, bonbons and sipping Evian water. They're usually working and exhausted, providing care that really doesn't match population health needs very well. And for the first time in our history, we have a generation where if you look at the population health outcomes, some are getting better, some are getting worse. You would think that if we're investing all this money in health and healthcare, people should be actually healthier, right? That's kind of a basic thing you would have thought we were operating on. But some of our problems are really getting worse. Now, some of our chronic disease rates going up is good because they would have died before. So if you would have died from AIDS in 1985, but now you have as a chronic disease, you're glad to be in the chronic disease stats, right? So it's not all bad. But our diabetes, that's a problem. Look at the problem with addictions across the country. I mean, what is going on? Mental health problems, right? Very, very difficult problems to handle. And yet, as I said, our focus is on emergency room, cure, and rescue, and that's generally not helpful to those kinds of patients. So we have a challenge. I often say this in our own work at CNA, to identify not just what are the right things to do, but how do we force ourselves to stop doing the wrong things? What should we not be doing anymore and not participating in that we continue? And how do we identify those and how do you actually do it? Because we tend, as I said earlier on, to revert to form pretty well. So in all this, there's us, nurses. And in repeated polls, as you know, for the last 20 years at least, including the most recent one in Canada, which was around March or April, nurses are the most trusted of all professionals. So I at the risk of sounding a bit Pollyanna, because I don't want to, I would say you could not have a better resource for any profession. What group of people in society wouldn't want to be said to, I trust you more than anybody else? That's a huge, huge privilege. People hand us their children. Take care of my child and I'll go home and sleep. Take care of my mother or my spouse. I mean, how many of us would hand off a child to a babysitter we didn't know? But we hand them to nurses all the time and say, I walk down any hall in this country and someone at some point will say, your nurse, oh, what's that thing? Can you look at this? You know, they want, I don't know what that thing is on your neck, but everybody wants your opinion on stuff. Shall I go to Emerge with this? I had a wisdom tooth out the other day, and I couldn't focus because the dental assistant wanted all kinds of advice on this rash on her hand, as if I know what the hell, I don't know about your hand. But somehow the nurse will know. The dentist didn't have a clue. But the nurse who's in the chair is supposed to talk to you about whether it's a rheumatoid arthritis flare-up or a rash from her garden. Like, I don't know. But people, that's a sign of trust, right? I respect that you will somehow help me figure things out for my health and for that of my family. It's a huge resource, and the challenge before us, is when you're in number one place, there's only one direction to go. And we have to be very careful with the precious resource handed to us of great respect. And I've been really concerned across the country with some of the stuff I've seen in newspapers with organizational fighting. Some of it's this category of nurse versus that category, or it's a regulator versus, not a regulator, a professional association, union, and so on. But the biggest concern we have in Ontario right now is that a nurse actually confessed to killing a bunch of people. And it's in the front, it's on the paper, it's on the Current, every day on CBC, it's everywhere. And she says, she gave lots of hints. Right? I gave lots of warning. Here's the 11 things you could have done to stop me. Now she's talking like that. Well, you know, the public is saying, well, maybe there's more of them. Like, is there a whole army of them out there, you know? And as I always say when I'm asked to speak about it, I actually don't believe there is. But our systems are not created to look for criminals. They're created to look for error, right? So we're looking for a missed medication, a double dose of medication, that sort of thing. Not for someone with a criminal mind who goes in and says, how can I be as deceptive as possible and get around? And that's what she did. But all that it takes is that across the paper, nurse killing patients, nurse killing patients. Well, that rattles trust, right? So we have to rein that in pretty fast. And, you know, I have some personal concerns when I've heard some of the comments made at the inquiry that, well, no, we're just following this policy or that policy from any side. I'm not talking about any particular person. And we would do it again. You would do it again? Be careful saying that. Like, maybe we should say, in retrospect, what I knew at the time I did, but maybe we need to review, blah, 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 because the public is watching and concerned. Nurses are a mighty force for change is something that Maureen McTeer said all through the year we did the commission. Some of you know Maureen McTeer as a prominent human rights lawyer, great defender of nurses. She was also the spouse of the former Prime Minister Clark and a prominent person. And she was always saying, nurses, great force for change. And I guess my own view is that we could be a great force for change if we were coalesced around some common language, working closely together. But when we look at 13 jurisdictions, 4 categories, NP, RN, LPN, and registered psych nurse in the West, union, professional, regulatory, and 46 specialty groups. Start to multiply that out. How many? 135 organizations just in a cursory count. So that's a lot of division across nursing within jurisdictions and at the national level. And probably it would help if we had some focus. We'll never speak all the same words and stuff, but Paula said so beautifully. Where's Paula? Oh, she's hiding, so she could probably making fun of me back there with doing an interpretive dance while I do all this. Hi, Paula. You know, about how we have different views and so on, but we're working towards the same goal. And I know she'll speak about that again later. The result is what you see here from Stephen Lewis, who's a prominent policy commentator, you know, who basically said that we don't have the kind of punch and influence that we should have given our numbers, our education, the high trust across the country. Best educated generation of nurses in history in this country right now. common education, relatively common education, baccalaureate for nurses across the country, common exams, common entry to practice standards, common competencies, common code of ethics, and so on. So why aren't you? What's that about? And he's always pushing and challenging nurses to pull that together so that we have take our proper place at those tables. So a small reminder of what we are trying to achieve, which is this quadruple aim. Do we want people to have better health? I mentioned that a few minutes ago. Fundamentally, people should be getting better. The care should be better value for the dollars that people invest, better nursing, and better experience for the nurses in the healthcare system, because we know when providers have good experiences that people tend to get better around them physically. We are being challenged to deliver the right care, so the right kind of care, right provider, at the right time and place, for the right cost. And we haven't quite got it right yet. We still have a lot of sometimes internal bickering around who should do this job versus that one, who can do this task versus that one. When we interviewed the public back in 2005 for the 2020 study, toward 2020, they said to us then very clearly, when I show up at the door, wherever the door is, a clinic, let's say, I do not care who meets me at that door. It could be a surgeon, it could be an LPN, it could be whoever you decide it is, because I assume you will have done the work to vet them, and the right person will meet me. What the public wants is access to great care. They are not fussed about RN, LPN, NP, and they keep telling us we're open to broader scope, open to many roles. But you would think the way we talk sometimes that it was a big issue. It's not a big issue for the public. It's a lot of our baggage that we carry around about that, but the public doesn't talk about it very much at all, as long as they feel that they have the right care and it's safe. Here's a message we give to governments all the time, and I hope that you'll share it too. Take the example of chronic disease management, which is where these systematic reviews came from. Nurse-led models of care are as clinically effective or more effective. In other words, they're as safe or more safe. They are as satisfying or more satisfying to patients, so the patients are okay with it, and are delivered for the same or less cost, so they don't cost any more, as traditional models. And what's the traditional model? A doctor, right? I mean, we just have to be honest. So in a country that says there's not enough physicians, New Brunswick has 20,000 people with no, right? What do you call it, Karen? Public?
On the registry.
On the registry. Across the country, sometimes up to 2 million people identified as not having access to a primary care provider. And we keep saying registered nurses, nurse teams, not just registered nurses, let's just say nursing, can do a lot of this. And the public says to us all the time, we will come to the nurse-led clinic. Where is it? Where is that clinic? In the meantime, I'm going to wait the 7 hours and emerge because I don't have any other choice. And I often say teasingly, assuming there's no CBC in the room, we nurses, having spent some time in emerge myself, we're mad at them. Here she is with her sore back. She has sore back for a week. She's coming to emerge. Here he is with his sore throat coming to emerge. Well, they're coming to emerge waiting for 7 hours, not for kicks, right? It's because they don't have any other place to go. Now, there's a few people who may be ER addicts and whatever. They got something else going on. I get that. But most people are there unwillingly and don't have any other choice. And the public has said to us over and over and over, create these. And let them come. And where there's nurse practitioners across this country, people tend to absolutely love them, and the outcomes are terrific. The nurse prescribing outcomes, by the way, RN prescribing, are fantastic. The early results from the last 10 years in the UK, unbelievable. No difference in the prescribing patterns, no more errors, patients satisfied, access improved. I mean, unbelievable. When I went to an NHS clinic I thought I had SARS in London in December. I shouldn't joke about that. So sick, I ended up having pneumonia. Had to go twice to a clinic. No physician in the clinic, no physician affiliated with it. 7 nurses, 200 patients a day, guaranteed to triage you within 2 minutes and out the door within 2 hours, full stop. Boom, 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 excellent care, prescribing. Like that's the thing. They're not, I said, you're not like a sub thing of a hospital? No, we're a nurse clinic, and they're all over the UK. And people get in and get care, so you're not sitting in emerge. You might sit here for 2 hours, but it's better than 7 in emerge. And I, in fact, didn't sit for a whole 2 hours. Great, great care. So we're being called across the country to optimize our practice. We get into this, let's just be honest, well, the LPN's taking my job, and the NP says, oh, the RN prescriber's taking my job, and the doc says, oh, God, those nurse practitioners, why don't they just go to med school? They just want to be doctors. It's all across the spectrum, while the public says, please stop it. Please just get me some care when I need some care. So my view is that nobody owns competencies. Lots of people can do any one thing. We say, well, this LPN can't give that injection. Well, the patient gets their own injection at home. Like, let's figure it out. You surely can't do that. Well, I was my predecessor, Helen Musalem, who was the CEO from 63 to 81, was in the first graduating class where they were allowed to do blood pressures, and the docs were revolting. Because that was just going to be the end of it, right? That was going to bring her all down. And now when you think about it, it's just so stupid. So history helps us understand people can do lots of things. And I learned when I went home with after a very major event with 2 PICC lines and a 31-inch incision, because I'm a large person, and 5 Jackson Pratt drains, which I call the Jackson 5, hanging off the front of me, sitting in like a lazy boy thinking, oh my God, I'm going to die. I would have cared for those patients in a step-down ICU when I first graduated. And I was in my home in the country, and every person that cared for me for 6 weeks was an LPN. And the care was great. I got better. So we have to give our heads a shake. Right? The system is different, the needs are different, the possibilities are different. The issue of change. We often talk about change to come in. I think, Laurie, I've heard you say this a couple of times about how change is all around us already. I have to watch my time. I can't see that clock. Okay, so maybe 10 more minutes or so, and then because we're going to go slightly past my time, and Sheila knows this, so we're just going to stagger everything a little bit. But Tim Porter O'Grady made this comment 15 years ago, and I thought it was an interesting one. Tim's a doctorally prepared nurse in the United States, that he thinks some of the challenge we have in our dissatisfaction with our practice and the struggle we have with feeling I can't get it done, I can't do the things I want to do, is because the way we're educated, deployed, regulated, and so on, is for a model of care that hasn't existed for a long time. There is no residency where people come in for 5 days and have their back surgery, or 7. My young sister, when she was born, 7 days my mom spent in the hospital. I don't need to tell you what the turnover's like now. Tim theorizes that if we approached our practice in institutions, at least, as managing mobility and turnover, and not had the angst of, I can't get the care plan done, I don't get enough time with the patients, and so on, that maybe we'd approach the whole thing somewhat differently. So it's something for us to think about, because his theory is that nursing practice model is completely gone, and we're still struggling to try to practice that way in a lot of places. His fundamental question is that we step away from volume, and we spend a lot of time with volume. No offense to our managers, because I was one, but we spend a lot of time with tick, 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 tick. Bed bath done. Did she get the meds done on time? Was the dressing changed? Da-da-da. And he always says there's no relationship between volume and value. Is what you're actually doing with the patient making a difference? And patients often say to us, you will have heard this, and it sounds old-fashioned, the nurse didn't have any time to talk to me. If they just talked to me, it would have been different. And we know that softer stuff, the care left undone, the talking to, teaching, and so on, is often what contributes to readmissions back to hospital. People go home and don't do well, or people who fall 2 hours later because they're in pain, if you just can stop and listen. But it's not the nurse's fault, because the nurse is doing what they're actually told to do. The nurses actually do quite well what we ask them to do, which is do all these things. But if you ask the patients what matters, it's not the same list as what managers measure. If you look at the Measuring What Matters report from London, University of Western Ontario, beautiful. And it says virtually nothing that we measure in all our quality programs and safety is anything that patients identify, which is about kindness, compassion, eye contact, communication, teaching, being with me when I'm scared versus focusing on the chemo, that sort of stuff. Not a surprise to most of us as nurses, I guess. Whoops, I think I might have gone too far. Actually, let's keep going because we're never going to get done. Let me play this brief clip. I thought you might be interested in the comments from Sister Elizabeth Davis. Some of you will know her. She's done lots of speaking, great leader in the healthcare system. She's now the Mother Superior, or the Mother Abbess, I think they call it, of the Sisters of Mercy in St. John's, but she's was the CEO of the first amalgamated system there in Eastern Health in Newfoundland. And I thought you might like her comments about change.
Now, all of this, we don't have time to develop this in any detail, but all of this talks about change. Change of an intensity and magnitude that no other group of humans has ever seen happen so quickly. Humans have always seen major changes, but nobody in past time has seen the intensity of change that you and I are part of. And the problem with change, good, bad, or indifferent, is that it's really hard for humans to bear. If tomorrow morning I were to marry Robert Redford, which I had wanted to do since I was 16, that would be traumatic for me, not to say what it would be for him. So the intensity of change to the good, remember the night before your own wedding, remember the night before your first child was born, remember the night before you got the job that means everything to you, times of stress. Change to bad is obviously very hard. You're burying your child. You've learned your father has cancer. Change to bad is really hard. The hardest change for humans to deal with is change to the unknown, the uncertainty. And the time you and I are cursed or blessed to live in is a time of incredible uncertainty. Just look at what one event can do. We talk about 9/11. We don't say it's a day and a month and what the year was. It's a short, very short little phrase that tells us so much. We talk about SARS. We don't have to explain what it is. Everybody shudders when you think about SARS. We have learned that one small event, what appears to be one small event, has the potential now to change the whole earth. So in this time of change, what we know for sure is we're losing absolutes. We're losing the symbols. Remember when nurses wore their hats and their white dresses? That used to happen in memory. Even nuns used to wear veils one time. We're losing the symbols that were symbols of stability. We're losing the structures that we were comfortable with. And as fast as we get comfortable with a new structure, it changes again. We're losing the relationships we could depend on, and we're losing the cultures that meant so much to us. And those losses are bringing with them incredible levels of emotion. Now, we have to trust, and I don't think...
Sorry, colleagues, I'm going to cut it off a little bit so we can get finished. Anyway, if you ever get a chance to see Sister Elizabeth doing one of her public presentations, I strongly advise you go. We're on this side now. Because she's a great, great, great speaker and philosopher, and you'll learn a lot. She's terrific. So, to sort of summarize things a little bit, I'm going to skip along here past a couple, because we will talk about them later. But some of our concerns in nursing I want to talk about quickly. First, we graduate still nurses in, okay, on this side. We graduate nurses still with a generalist degree in a world where the practice is nearly entirely specialized. There's very, very few, except in rural settings usually, of the old idea of med-surg units left. And in our own certification program at CNA, the specialty certification program, people are failing the med-surg exam because the medical nurses can't pass the surgical part, or vice versa. There's one group that can't do there's one that's okay, but one isn't. And they're asking us to split it. So the fact that the traditional generalist med-surg exam isn't even passable by people practicing in that area tells us something interesting about the way practice has changed. So we need to think about how we bridge people from the generalist degree, and there doesn't seem to be any appetite across the country to change that, into a world of high specialty. And so far, we haven't done anything that I've seen to require that. I've graduated, I've been in healthcare for 40 years, but I graduated from the BSCN 35 years ago. in Ontario, and I've worked in Manitoba, but I've never been asked once in 35 years, never once, did you ever learn a thing? Prove that you took a course? Nothing. I'm supposed to reflect on my practice in case I get audited at some point. Now, they can check me, and they know I've got a master's degree, and I'm probably not the one they're worried about, but in a world of what we just talked about with that inquiry, that people should be asking about that, right? That's a concern. So we make the physicians like certify every year, right? They're members of the College of Physicians and Surgeons. They have to say, I did this many surgeries, I read this many articles, I wrote a paper, I did a piece of research, whatever their criteria are. We may need to think about how we're going to do that for nursing. Do we need an internship? Do we need a residency to bridge people from the end of the school year into those highly specialized units? And should we make it a requirement that you must have a specialty certification of some type within X number of years of graduating? I'm not saying we should. I'm asking the question. We don't do a very good job articulating our value. It's hard for us to say, look, this is what I do in a day. I make this much money, and this is what I contributed, this is the outcomes, and this is what it cost. And we're often seen as the highest cost in the system because we're usually the highest HR cost in a nurse-intensive place like an ICU or in a hospital, and it's an easy cut. Just cut nursing. Cut 10% because there's 425,000 of them. So what if we're down a few? Well, when you're on the individual unit, down even one, right, can mean life or death for the people. Life or death for the nurses and the workload. But it's an easy hit if we can't say, no, here's the systematic review, here's the evidence. Now, if you want to choose to work nurses to death, again, your choice. But do it knowing the facts and do it knowing the value. We know, for example, in the United States study in Boston, beautiful study of school nurses. I have no idea what school nurses are actually doing, but it's in the study. Every dollar invested in a school nurse returns $2.20 in productivity for society. Less trips for the family coming to get a kid to go to a doctor, less doctor trips, less gasoline, less people missing work to be home with the kid. Because a nurse in a school probably says, go lie down for half an hour, you're not dying, or whatever they do. They prevent all kinds of stuff. Simple intervention. And we know that every nurse in a hospital in North America generally returns about $60,000 in productivity back to society. We have to be able to understand that. You want to take 50 nurses out of, I don't know, Moncton General, whatever the name of the hospital is? Okay, but do it knowing, be aware. And we don't do a good job of talking about that. The last thing I think that really concerns me is I think nurses, that's funny, that's in a different place. Anyway, it's okay. Nurses are kind of tired or are completely exhausted. And most nurses are female, and in our society still have the burden of a lot of care, often before and after work. So we know that we want the nurse to show up for 8 hours or 12 and be charming during that time. And then also do some work to support the professional association and CNA and the profession, and then go home and care for some kids and make some lunches and be happy about it all. So that's a tough call. And Vince Lombardi, the great football coach, sorry, this is somehow going off the screen, often used to say, fatigue makes cowards of us all. When we're tired, we don't make courageous, great decisions. And I know myself when I'm tired, I just think, I can't fight that today. I'll let it go. And sometimes we let stuff go that's important, right, that you should do today. There's things in the last 24 hours, I was saying to you last night, I just couldn't face doing emails after we worked all day, and there's some things I probably should have attended to, and you tend to retreat. And we don't want nurses to feel that they're always in retreat from fatigue. I'm watching the time. I should probably wrap up. Okay, 5 minutes. So let me pass this and talk about a couple of opportunities, because I think that's important, then I'll close. They are some of these opportunities are these. First, there are giant existing gaps in care across the country that we could fill. We hear all the time that there's a great need for nurses in long-term care, home care, communities, and so on. But we have historically gravitated very strongly to hospitals. And when hospitals came to be, largely around the time of the Second World War, because before that, most people just went, had their care at home. Only poor people went to charity hospitals and religious hospitals and so on. Nurses flooded into those. Because some of it was very interesting. It was sparkling and new and different, and it was a place where you had regular hours and predictable employment and good salary and so on. And some of it was that it's just plain exciting. And now we have a problem where we often say, just more home care, just more long-term care. And I often say, I don't say this to media, but I say to nursing groups, well, where's the wave of nurses saying, God, please let me get to work in long-term care? Because we don't see it. It's a recruitment challenge like it used to be in mental health and neurosurgery. There's always some areas that were hard to recruit. So if we wanted to take over and say, look, we could make the most sparkling, fantastic aging care system in the world, we nurses could take that all with our existing practice. We have to actually want to do it. The pay has to be there, the positions have to be there, the funding. So there's a lot of work to do. In Ontario, the new premier said, as part of the campaign, we're going to have 15,000 new long-term care beds. Okay. Well, where? And how are you going to staff those? Like, who's going to run those 15,000 beds? Major, major challenge. Much of the care for the next 30 years is the kind of, falls under the kind of scope nurses can do now. So that's a good thing. We don't even have to advance our scope. It would be good if we did. But we are able to do it, and the calls for dramatic sort of dehospitalization could pull us back to our roots. I think we need to think carefully about technology and how we use it and how we don't. I remain concerned that we don't use the sort of technology that's even in our hands, and there's all kinds of rules around how and who and where and what can you say and what can you do. But we ask people of all ages, certainly young people coming out of school, to step into the hospital door and largely put this away and be happy stepping back 10 years. Like, come to this place and see what fax machines are. Most of our students that I teach at U of T have never seen a fax machine until they go to the healthcare system. And my doctor thinks it's a victory that they can fax a prescription over to Shoppers Drug Mart. Fax? Like, why fax? Anyway, there's all kinds of technologies which we could take advantage of, and some of them that we use phones and people can take their own blood pressures and so on and connect with nurses, extend our reach across the country, and yet we don't. One of the technologies I think would be helpful in an aging workforce is one like this. I won't show very much of it, but this is Asimo, the robot. There's all kinds of them around now, different models, expensive but useful. And in studies that show that nurses change positions 27 times. You can turn it down a bit, John. The nurses change positions 27 times every 50 minutes. Why wouldn't you have something to go fetch things? Cute, eh? And that they can walk stairs, carry trays with drinks on them, like they're very helpful. Could run for blood products and so on. John, we can turn it off, please, thanks. So, this is my last thing, and then I'll play that little video, and then we're done. Or should I just skip the video today? I just wanted to close with this sort of semi-final message, I guess, which is, it was a doctor who said at a conference I was at, he thinks we do a great disservice to the people coming into nursing and medicine by the way we recruit them. And he said, what if we recruited people into a profession that is called the care of aging? Because most of the people that we will all care for are older people. But you wouldn't know that. Something feels like it's going on behind me. Anyway, you wouldn't know that even by our education. And I'm not being critical of our educators. I'm just talking about our general approach. We still have largely models where in the middle 2 years of a BSCN, you have a med-surg for 4 months or whatever it is term, a labor and delivery term or a women's thing term, a baby and peds and psychiatry. Most of us in our career will never see an infant. Never, unless we work in Emerge. How many of us will ever actually be called on to deliver a baby? So what is the 6 or 12 weeks of labor and delivery? It was fun, and I enjoyed that experience, and I ended up working in outposts where I did have to deliver, but most of us don't. So what if it was framed as the care of elderly people with occasional interactions with young people versus you're mostly going to learn how to care for young people, and then you get out there and go, oh, they're all old in this ICU. Well, guess what? Most people who are sick are old. Like, 20-year-old athletes, well, the trauma patients, right? But other than them, most of those patients are older people. I picked the image on purpose because it's from CNA, and even that image, right, doesn't speak to older people or elder care or seniors or aging or home care. It speaks to what attracts us: action and masks and equipment. And I manage the 14 pumps. So we're asking you to do a lot, to think about a lot, and I want to leave you with a little bit of what I think is some encouragement from Maya, and then I'll get off here. And I hope I haven't totally destroyed your shortened 10 minutes there, Sheila. And then we're going to have a break. This needs sound, John.
Maybe the hardest part is if you teach, you have to live your teaching. You can't say, you do not as I do, but do as I say. No. You have to say, I'm doing my best to live what I teach. I have a painting by Phoebe of a group she calls Sister Sufi's Funeral. And all the women, there are about 9 women, and they all look like women in my grandmother's prayer meeting group. So whenever I'm obliged to do something, I take that painting and I look at that painting. There's an empty chair. And I think, now what would Grandma do? What would she say? I can almost hear her voice say, now, sister, you know what's right. Just do right. You don't really have to ask anybody. The truth is, right may not be expedient. It may not be profitable, but it will satisfy your soul. It brings you the kind of protection that bodyguards can't give you. Try to be all you can be, to be the best human being you can be. Try to be that in your church, in your temple. Try to be that in your classroom. Do it because it is right to do. See, people will know you, and they will add their prayers to your life. They'll wish you well. I think if your name is mentioned and people say, oh hell, oh damn, I mean, you're doing something wrong. But if your name is mentioned and people say, oh, she's so sweet, he's so nice, oh, I love, oh, God bless her. There you are. So try to live your life in a way that you will not regret years of useless virtue and inertia and timidity. Pick up the battle. Take it up. It's yours. This is your life. This is your world. I'll be leading it long before you under the ordinary set of circumstances. You make your own choices. You can decide life isn't worth living. That would be the worst thing you can do. How do you know? So far. Try it. See. So pick it up. Pick up the battle and make it a better world. Just where you are. Yes. And it can be better, and it must be better, but it is up to us.
So as you enter into your day of deliberations and discussion, I hope that you're encouraged around the battle ahead, not battle, I guess the tough work ahead as you take it up. And I'm happy that we'll have lots of chance to do questions and talk through the day, and thank you very, very much for coming this morning. Thanks, Ken.
And thank you, Michael, for providing us with a lot of thinking in a different manner, and I'm hopefully this will promote the discussion throughout the day. Jennifer would like to take a picture of the group, so we're asking if you could all put on your shades that are provided. She'll take a picture from one side, then the other side.
I'm going to do it in 2 pieces.
So we can get a picture to post. So the coffee and refreshments are in the room to the right when you exit the door.
Look here.
There's also the spin the wheel and lots of information out there that you can drop by, and we'll resume in about 15 minutes. Thank you.